Assalamu alaikum and very good morning to everyone. I'm going to discuss again an essential topic of oral medicine, or you can call it even into the subject of oral surgery, that is trigeminal neuralgia. So, first of all, we should understand what is trigeminal neuralgia. Before understanding trigeminal neuralgia, I would like you to have a good recall of the trigeminal nerve. We all know that it's a fifth cranial nerve that is called as trigeminal nerve. Why do we call it a tri? Means three. Okay, it has three branches. So it is fifth cranial nerve, basically, if we say according to the number of the nerves, and it has three branches. If you see a branch going towards the forehead and eye, a branch going towards the maxilla, and another branch going to the mandible. So that's why we call it a trigeminal nerve. And it supplies different part of the face. Like if you can nicely appreciate in this picture, it is the ophthalmic division of trigeminal nerve is supplying your forehead, eye, and some part of the nose. And if you could see this branch that is called as maxillary branch, it is supplying most of the part of the maxilla along with zygomatic bone and the lateral surface of the eye. And if you see this third branch that is called as mandibular branch of the trigeminal nerve, that usually supplies the lower part of the face. So trigeminal nerve, again, it's a fifth cranial nerve. And this nerve, a problem with this nerve, trigeminal nerve, or any cause, any disturbance with this nerve, that is called as trigeminal neuralgia, we are going to discuss in detail. So before, like earlier, this trigeminal nerve problem, neuralgia, was called as Tic-Dolerix, or then later it was named as Fothergill, and also trifacial neuralgia. But out of all these, the trigeminal neuralgia is a very common term which is used. Tic-Dolerix had been used, this had been used, and trifacial neuralgia had also been used as a term, but the most common term that is used is trigeminal neuralgia. As I told you, it's a fifth cranial nerve, the problem with the fifth cranial nerve, and once it is supplying your face, so definitely patient will complain of the issue with his face. Okay. Most common division, as I told you, there are three divisions, 1, 2, and 3. But the most common divisions involved are V2 and V3, means maxillary and mandibular. Sometimes V1 is also involved, but that is very common. And patient will complain of the pain usually on one side. It does not cross the midline normally. So it normally affect one division or one side, because on right side, there's the separate branch of trigeminal nerve or division of the trigeminal nerve, and on the right side there is a separate. So usually the pain or complaint is unilateral, not bilateral. Okay. So whom it affects and when it affects, we'll talk about. But first, we should understand there are several types of neuralgias of trigeminal nerve. One is called classical type of trigeminal neuralgia. Other is called as secondary trigeminal neuralgia. And one is called as idiopathic. Okay. So what happens into the classical type of neuralgia? It is due to neurovascular compression. It means there is a compression over the nerve. This is the nerve. By any means, there is a compression over the nerve, and this compression is called causing the problem. Okay, and compression over the trigeminal nerve trunk can also happen. Okay, so this is resulting into the typical type or classical type of trigeminal neuralgia. There are other type of trigeminal neuralgias are secondary type. That is not directly caused by compression of the nerve or compression of the nerve root. That is caused by multiple sclerosis, that is caused by tumors or cerebellopontine angle lesion. Means the cause is different other than the compression of the nerve or compression of the nerve root. And third is idiopathic. There is no clear cause, but investigations later clarify that what is the reason behind. So we are actually talking about the classical type of the trigeminal neuralgia. That is actually a true type. So what type of pain it is? It is a neuropathic pain because it is coming from nerve. Patient will complain of repeated brief attack of pain, if you can see in this picture, and patient will complain these are the classical signs of this pain. electric shock-like pain, stabbing, shooting, and lancinating. Basically, this term differentiate or describes that this is the pain of the trigeminal neuralgia. Patient will complain that I have a pain, but between the episodes of the pain, if first episode patient got and then after that he got the second episode, after 30 minutes in between these episodes, patient will not complain of any pain. He will be pain free. But these episodes, when he has attack of the pain will be shooting, stabbing, lancinating, and basically electric current like pain. And when this patient will be triggered, there are the different triggering factors that trigger this pain. So as a dentist, we must know what are the triggering factors of the pain and what pain does it mimic. What sometimes it is mimic with dental pain. So sometimes, like when we are unable to differentiate between the trigeminal neuralgia, because definitely when we said that the maxillary and mandibular division of the trigeminal nerve is involved. So it means that the maxillary division is supplying your teeth, mandibular is also supplying your teeth, gingiva, upper jaw, lower jaw, and face. So patient will come to you and he'll complain that he has pain in the teeth, in the jaw, in the gingiva, and we sometimes, we are unable to differentiate between the neuralgic pain, and we think this is the dental pain. So we begin with root canal treatment, extraction, periodontal treatment, and even then, patient says, "No, my pain is not relieved." So, being a dentist, you should know that every pain patient complains often to the oral cavity cannot be the pain of the dental cause. It could be the pain of the other cause. So we need to differentiate this pain. So what are the features that actually are classical signs that are present? As I said, it's a unilateral, never cross the midline, sudden onset, patient will have a severe intensity of a shock-like pain, and it will have brief, period of, comfort, and then recurrence quickly. Okay, but as I told you, between the period of attack, the attack-free period is where patient will not complain of any pain. And it is triggered by stimuli. Where there is a distribution of the trigeminal nerve. If we touch any trigger or any division of the trigeminal nerve, patient will complain of the pain. So what are those basically triggers? If this picture can easily tell you that if patient says, when I brush, I feel pain. When I'm making my beard, I feel pain, because beard is in the area where the trigeminal nerves distributions are there, mostly the maxillary and the mandibular. And when the patient says, I start eating and biting, I feel pain. When I touch this region, I feel that I am having, sudden electric current. And when I stand in front of air, direct air, or when I, travel and I cannot keep my windows open. So when the direct air hits my face, I feel pain. So within 24 hours, patient can have multiple attacks of the pain due to several different triggers. Okay. And pain lasts up to 2 minutes, from few seconds to 2 minutes. And I told you, then comes a period when the patient has no pain, and then again any of these activity when patient performs, patients start complaining that I'm having pain, and it's a current like or electric shock like. Okay, so these are the triggers of the pain, and as a dentist we shall know that these triggers where and when are these triggers present. Okay, so again, I repeat, washing face, brushing, chewing, talking, touching face, cold air, drinking water, smiling, applying for the ladies, applying makeup. These are all the triggers of this pain. And these trigger zones basically are, as we said, usually the V2 and V3. A branch of trigeminal nerve is involved. The patient usually complain of pain in the nasolabial fold, upper lip, lower lip, gingiva, cheek, and chin. Okay. So that's why we ask patient do not touch the triggers anymore. Anyways, we come to the investigations it's a key rule that for the investigation, you need to begin with the history. You need to take the history of a pain. That is that will tell you exact, definition of the pain, what sort of pain it is. So we use the term Socrates, as you know, and based upon the Socrates, we ask the patient the site, the onset, the character, the aggravating factor, relieving factor, intensity, and all. This helps us, in differentiating one pain from the other pain. And in any previous treatment, if the patient has if patient is getting any sort of medication. So these help in making the diagnosis of the trigeminal neuralgia. Then comes the clinical examination. We observe the patient's facial symmetry. Sometimes due to the pain, patient has, sign of grimace, a sign of fear on the face. So that's why there may be facial asymmetry. There may be swelling. There may be, any other, anything which makes you feel that the face is not bilaterally symmetrical. Then we try to test V1 with testing with the instruments, with light touch or pin prick. We test V1, V2, and V3 branches of the trigeminal nerve. Then we continue the examination of the MOM, muscle of mastication, the examination of the cranial nerve, corneal reflexes, and TMJ examination. So these are all the examination we perform extraorally. Then comes the intraoral examination. Again, we need to exclude the cause. If the patient has dental caries, if there is a cracked tooth syndrome, if there's pulpitis, apical periodontitis, periodontal abscess, pericoronitis, sinus-related pain, or any failed treatment, because we need to rule out the cause. So that's why we have to go for thorough extraoral and thorough intraoral examination to understand that from where is this actually pain coming or arising. Okay, so other investigation, that was our history and clinical examination. Other investigation, we perform our pulp sensibility, periapical radiographs to exclude the odontogenic cause of the pain. Then we obtain baselines as OPG. And for thorough or proper evaluation, we can obtain CBCT or MRI if that is due to compression of the nerve. Then management, we manage the patient with first-line medication, that is carbamazepine, and basically the carbamazepine is the oldest and first-line medication still used. But we need to start it. You and me cannot start it, but definitely a physician is going to start it with the low titer. Gradually, they rise the dose of the drug. Then oxcarbazepine, that is also an alternative if the patient is unable to tolerate the carbamazepine. Okay, oxcarbazepine, that is well tolerated if we compare with this. Then we have alternatives we can add on are lamotrigine, baclofen, gabapentin, pregabalin. These are other options if patient is unable to use these medications due to side effects. And the last resort is you provide injection, that is botulism toxin to the selected area, or surgical option if the patient is in the refractory phase. So before starting any medication, specifically carbamazepine, oxcarbazepine, you need to have some baselines in order to have a complete picture of patient's profile. That include your patient's blood profile, liver function test, renal test, electrolyte, especially the sodium, and drug interaction review. This is very important in order to prevent patient from systemic illness that is caused by the drawbacks or side effects of the medication. So that's why we need to evaluate the patient thoroughly. In acute severe attack, now we are going to go for treatment. In acute phase, when the patient has come to you, you need to first perform those treatment options that gives comfort to the patient, and those are usually hospital based. In hospital based management, you apply topical anesthesia to the affected area. You can go for intranasal lidocaine, these puffs to the patient. We ask the patient to avoid touching the trigger points. We can prescribe patient with intravenous medications in the hospital, and we ask the patient that try to avoid, brushing to the specifically to particular region where the trigger is present. Avoid, shaving to the lady. Avoid applying makeup. Do not go directly to the cold air. So we ask the patients that take the precautions and avoid these triggers. Okay, so that was acute treatment. Now, after the acute phase, treatment, we ask the patients with precautions and then we perform the surgical procedures, or not always the surgical procedures. There are some minimally invasive procedures we can also perform. One is called as percutaneous, where you are not going to perform surgery, but you are going somehow from the skin. So one method of treating this trigeminal neuralgia is through radiofrequency thermocoagulation. That is percutaneous method of treatment, and we will be applying this radiofrequency thermocoagulation to the affected nerve directly through the skin. Another is called this balloon compression. And again, we go through the skin, and this balloon is actually taken towards the ganglion, or towards the main, not the ganglion, but basically the main branch from where this trigeminal nerve is getting distributed into other three branches. So that is called this balloon compression. Then in the balloon compression, what doctors do, that they take from percutaneous, through percutaneous means, they enter towards the exact site from where there is the trunk is dividing into different branches, and then they place the balloon in. Similarly, there is glycerol injection. This glycerol injection is also given, purposely in order to produce some chemical lesioning of the fibers. Patient is, again, through percutaneous mean, this glycerol injection is taken inward, and to the affected nerve, this glycerol is injected. And this glycerol is actually a chemical. What does it do? After leaking to the particular site, that cause some lesioning, breaking of the fibers. And these fibers, when these are lesioned, this is actually a mean of giving comfort to the patient. But these are given to the patients when we are not going for the surgical procedure due to any means. Okay, maybe patient is not fit for surgical procedure, so we have to go for treatment via percutaneous method. In surgical methods, what do we do is we perform decompression method. Okay, because we said that the classical type of trigeminal neuralgia occurs due to compression of the nerve. And when the nerve is compressed due to these heavy arteries, assume these arteries were directly applying pressure to this nerve, and we want to produce decompression. Okay, so what surgeon does, he produces some external cut over the region of the mastoid, and you can see this thing. This is placed in between the arteries. Arteries are separated from the nerve, and these actually are these sponges are placed between the artery and the nerve to avoid pressure which is occurring directly due to vessels over the nerve. So this is called as decompression method. We are we are reducing the compression over this particular region of trigeminal nerve. So after the vascular decompression method, there are some other minimal invasive procedures again for the subjects who are not fit for the surgery. These include stereotactic radiosurgery. Means we are not going to perform any cutaneous treatment. We are not going to go for any surgical treatment. By means of some radio or stereotactic rays, we are actually giving some sort of relief to the pain to the patient. So these are all the methods that by which we can treat a subject with trigeminal neuralgia. I hope I'm clear. If you have any query, any issue, you can send me a message on the given number via WhatsApp, or you can give me, you can leave an email. I will reply you, inshallah ta'ala. Thank you so very much. Remember in duas, and hope to see you with the next video, inshallah ta'ala. Thank you.